as to in whose brain is that. And so that injury occurs in context of the preservation of other brain areas and brain functions. So we all start off with our pre-injury, with our psychological and cognitive resources. We start off with our own liabilities. We start off with our own coping resources. Sometimes we are depressed. Sometimes we're anxious anyway when an injury occurs. But that injury occurs in context of an individual's brain. And so, and that individual brain exists in context of a larger social environment. So then after the injury, we have either transient, as in the case of concussive mild traumatic brain injuries, in many cases, not all, or we have permanent cognitive impairments that may not recover. A critical stage in the recovery process, and as it relates to vocational rehabilitation, is when that patient starts to become aware of their own impairments. And that awareness, the emergence of awareness usually occurs in stages. So initially a patient may become aware of their physical difficulties because they are so obvious, but they may not be aware of their cognitive difficulties. That awareness usually takes longer, and it may not occur until they resume or try to resume some of their pre-morbid previous activities, like returning to work or trying to balance their checkbook. And all of a sudden it may become clear to them that in fact they're not able to function exactly in the same way. But how we manage that awareness, the emergence of awareness from an outcome standpoint, becomes critical, because we respond in a variety of ways to when that process occurs. Paradoxically, the emergence of awareness typically happens when people leave the hospital, whether it be the acute care hospital or whether it be the rehabilitation hospital of some kind, because when you're in the hospital setting, you have nurses, you have therapists, you have family, and people are doing things for you. There's structure in the environment, and it's a novel environment, which in a way insulates the patient from confronting the effects of their injury on their day-to-day functioning. But as soon as they leave that structure is then when the awareness typically emerges. But at the same time, the problem is that's often when patients have the fewest resources available to them to know what to do with that when it does happen. So when as that awareness emerges, and it's a scary phenomena. So imagine, put yourself in the patient's shoes. You wake up in a hospital. You don't know how you got there. And you find that people are doing all of these things with you and to you and for you. I think it's a natural response for most of us to feel that we are either fine or we're going to be fine, and so then you all of a sudden find that you can't write your name, or that you can't remember your spouse's name, or that you can't pick up your right arm, or that you can't see, or that you can't remember. And it's that reality and that confrontation sets the stage for the possibility of a significant emotional reaction to that. And not only for the patient, but for the family just as well. So what we know is that about 60% of our people who have brain injury develop depression or develop anxiety or post-traumatic stress disorders or others, particularly when right following when the awareness of their impairments emerges. On the other hand, the opportunity that we have, and we see this in some patients who have a great deal of emotional resilience or have incredibly supportive families, we see that those comorbidities can be prevented. How can they be prevented? Well, they can be prevented by education. They can be prevented by a great deal of emotional support and feedback and encouragement. They can be prevented by a trial on an antidepressant. And in fact, one of the studies that I've done at RHI is on the use of antidepressants for the prevention of depression following injury. And what we found was that those patients, in fact, of course, didn't develop depression as often, but we also found that they got better cognitive recoveries with a preventative trial of an antidepressant. So if we can prevent those comorbidities from emerging, may that set the stage for a better recovery and avoidance of a decline in functioning. So if we take it the next level, and I talk about this model as a biopsychosocial model, and it's a biological model because of the injury and its effects. It's a psychological model because, of course, that is a part of our functioning and a part of our brain, and a social model, which is now this outside level of this model I want to talk about. So in the case when comorbidities do emerge, what are the reactions that most people evidence when they become depressed or they become anxious? Well, they withdraw from their natural supports. They withdraw from their family. They withdraw from their friends. They isolate themselves in their room. They watch TV all day. And what if you happen to have a lack of support network? Or if you have a family that is making fun of your disability? Or if you have a family that avoids you? That's a different context and a different stage, or a different, it sets a different context for that individual at a social level who's trying to recover. On the other hand, what if we have the situation where we have a very supportive family network, where we have supportive friends involved, where we have the possibility of getting out into the community and participating in activities despite our disability? So now we have two rather different scenarios emerging, and of course no one individual, or seldom does any individual not struggle at some level following these sorts of injuries. But clearly some people have psychological and social resources that really do propel them through the recovery process, and clearly others have catastrophic, serious comorbidities develop in context of very unhealthy families that make the recovery process much worse. So in trying to then understand how does this affect the long-term recovery, what we need to think about is that in this scenario where the comorbidities have emerged, now they're using drugs again and they have no family support, there's going to be a gradual deterioration in their level of functioning, in contrast to this other individual who may then have the resources to adapt much earlier and much quicker to the challenges of their situation, which has the effect of lessening the relative effect of the very same injury, where in this individual they may lead to experience a course of deterioration, which increases the relative effect of the injury. And so when we looked at those earlier data, it may not be, of course, that there's something happening to their brain that's getting worse, or the injury inside of their brain, but something is happening to the donut, not the whole, that causes a degradation of function. And another example of this is if this is our brain and we have an injury in there, and because of depression there is a biochemical depletion of serotonin, then that healthy brain that's unaffected is less able to compensate for the effects of that injury. If I have a patient that's got an injury in their brain and they're smoking cannabis 3 times a day, then they're less likely to be able to compensate because of the biochemical effects of that for the effects of their injury. So these are some of the biopsychosocial factors that drive this. And when we're doing resource facilitation and we're managing resource facilitation, we're always trying to think about what do we need to do here to prevent comorbidities? How do we anticipate that? How do we engage them psychologically and socially to lessen the relative effects of that injury and get them returning to work? So I just wanted to kind of lay that out from a conceptual standpoint. And if there's any questions about that, I'd be happy to take those at this time. So, okay, doesn't sound like it. If they pop up, why dive in? So on here, what I want to just talk about briefly is that this HRSA grant and all that it has brought and the resource facilitation has also set the stage for us to kind of develop a new sort of neuropsychological examination that does not replace a traditional neuropsychological examination, but we've developed this examination to particularly guide the resource facilitation process across the model that we just discussed, and also to address the issues in the research that have been shown to prevent return to work. I wanted to develop an examination based on research so that we were identifying risk factors for failure to return to work and identifying factors that were associated with successful return to work. So we have in one situation, sometimes what is appropriate is a traditional neuropsychological examination. Sometimes what's appropriate is a much more resource facilitation oriented examination. And a vocational counselor can request either of those. It depends on what you want to know. In the case of the traditional neuropsychological examination, what the patient is going to get is a very comprehensive assessment of cognitive, motor, and sensory functions. So, and in the cognitive domains, we're talking about language and visuospatial functions, attention, different kinds of concentration, attention regulation, executive functions such as problem solving, sequencing, planning, organizing, and the like. And then they're also going to get an assessment of their psychological and emotional status. So that the domains of that more traditional examination are fewer, but the depth is greater as it relates to particularly the cognitive assessment that goes into that examination. In contrast, the examination for resource facilitation has a broader scope. So it may not have the same depth with respect to the cognitive domain, but it has a broader scope. So in this examination, excuse me, we're also looking at and assessing family coping and available social supports. We're also assessing what is their status with respect to transportation. Are they driving? Are there people that can drive them? Are there family members? What access do they have to transportation? We also assess substance abuse because, of course, that's a known risk factor. Flexibility with vocational goals turns out to be a huge predictor of return to work, and as you would expect, those people who have very high and very narrow expectations are less likely to return to work in the research as compared to those patients which are more flexible or malleable in how they see their return to work options. We'll also need to look at endurance, both cognitively and physically, because you need to have some endurance from both domains as it relates to returning to work. And of course, we're going to assess awareness and acceptance. Where are they in that process? And what are the implications from trying to prevent comorbidities as they are likely to arise? And then, of course, we also assess the cognitive and neurobehavioral and psychological status like in the traditional examination, but instead of 7 hours of testing or 6.5 hours of testing in that domain, it may be 3 or 4 hours in that domain because we want to capture a larger scope from which to drive the resource facilitation process. So the purpose or the results that come out of these two different examinations, first of all, for the traditional examination, is a differential diagnosis, because sometimes we don't know what is causing a given problem, and the purpose of the examination is to make that diagnosis. So is it depression, or is it the effects of a concussion? Or if it's both, how much of each is it that's causing the difficulties in day-to-day functioning, as an example. It's to determine the type and severity of very specific cognitive impairments. And we may be wanting to set the stage for cognitive rehabilitation and may need some pretty high-resolution data, for example, in terms of where does their memory break down, and in under what conditions does their memory work really well, so that then we can guide that cognitive rehabilitation process with respect to their impairment of memory. And as mentioned, of course, to determine their psychological status, and as a consequence of all of the above, what sort of cognitive rehabilitation services may they need, and what sort of psychological or psychosocial interventions may be appropriate. In contrast, for the resource facilitation evaluation, we're going to get an overview of what are the cognitive, behavioral, and psychological and social effects of the injury. So this is the broader scope. We're not ignoring their cognitive status, but it doesn't have the same level of resolution. But we're also going to ask, what are the social effects of that injury, and how is the family? We're going to look at what are the potential vocational barriers, and we're going to, and those will be identified in the report. But we need to know also what are the available resources that they have, and what don't they have, as it may relate to their return to work, and then that sets the stage for the plan for resource facilitation. So a vocational counselor can get either one of these. It depends on what they want to know, and the information you'll get out of those two is different. At least from an RHI standpoint, the Rehabilitation Hospital of Indiana, I can say that both of those are priced the same. It doesn't, there's not a price differential. It's simply an issue of focus or priority. So just wanted to share that perspective with you. So now I want to emerge towards talking about this case. And this is a case I know that both Pam and Rebecca have enjoyed working with. And one of the things that I think that when we talk about resource facilitation that affect return to work, you know, what we're using here in looking at this biopsychosocial model that we looked at is trying to drive this process from a comprehensive or a holistic perspective, because you can fail at returning to work for any of those reasons in the biological, psychological, or social domain. And so the issue is okay, in the process of doing resource facilitation, what is it that we're trying to access to promote that return to work? And why does the resource facilitation model seem to be working so very well? Well, the first issue is resource facilitation gets access to people who are truly specialists in brain injury, which I'm going to argue is a critical success factor. Outpatient therapy is not outpatient therapy is not outpatient therapy. There's huge variation in what's done and how it's done and to what extent it's driven by the evidence. The next issue is access to social supports. So there are all kinds of natural supports. There are all kinds of purchase supports that can be used to promote social integration and community reintegration. Some of them are highly specific to that individual and that family, and some of them are rather generic. But it's important to promote access. We also talk about access to instrumental support. So sometimes resource facilitation has got to help help someone with their disability application. Sometimes a resource facilitator has got to help them access funding for a service that is where funding is required. So those are access to kind of instrumental supports. And fourth is access to community support. So that may include the local Brain Injury Association of Indiana support group, or it may include a particular community support that's unique to Terre Haute or to Newcastle or to South Bend that's available in that community to help that individual with something that's been identified as a potential barrier. So I think it's these four domains, if you will, that where we look to access resources that is going to influence the return to work process. So I just wanted to share this, and we'll talk about this in context of this case and what resources were accessed according to these domains. But it's again driven by the issues unique to brain injury, and it's comprehensive. And I think those are some important underpinnings, if you will, for how you drive the resource facilitation process. So the things that I want to get out of this case, this case is a very interesting one, and there's some really 4 points that I think this case really illustrate. And the first is that severe injury does not always equal severe disability. There can be some significant dissociations. Sometimes we have patients with mild head injuries that end up with severe disability, and sometimes we have patients with severe injuries that end up with mild disability. And so they don't always go together at all. This case is also interesting because this patient had extraordinarily little family support, and in fact antagonistic family support as it related to accessing services. The third interesting thing about this case is that he fortunately did have access to specialized brain injury services, and it's for these reasons that I asked Rebecca to join us from IU in this case presentation. And lastly, that comprehensive treatment was essential, and that is that we address all of those 4 levels that we talked about in this slide to enable this patient to return to work. Because if it's return to work and brain injury, the reason the outcomes are often so poor is because it's like sometimes a house of cards. If you pull one card out, the whole thing falls apart. And so it's the resource facilitation process to try and make sure that the cards get put together in the right way, and that the supports are in place for it to stay together. So these are the 4 points that I think we'll see as we talk about this case. I'm going to shift here a second. Rebecca, I trust you're on the line.
I am.
Yeah, thank you very much for joining us. This is a patient that Rebecca has worked with for quite some time, and Pam is here with me as well. And so what I've done, Rebecca and Pam, is pulled together some information about this patient, but if there is something you want to add or insert at any time, please just do so. Is that okay?
That's fine.
Okay, so this fellow is a 51-year-old fellow that's actually had 2 traumatic brain injuries. And everyone may not know this. Traumatic brain injury, if not well managed and well treated, is a risk factor for another brain injury. And it's simply because if your brain is impaired, you are more likely to have impairments of judgment and impulse control. And so yeah, it's a risk factor for a second injury. This fellow was working on the farm, as I recall, or as I read, I think, Rebecca, in your report, when he was hit in the head by a tree. Interestingly, I don't know how he was hit in the head by a tree, or if the tree fell on his head, or exactly how that happened. And interestingly, the patient reported to you, Rebecca, that there was no loss of consciousness, but that he had a craniotomy. And I don't know if you've learned any more about him in the interval, or the effects of that injury.
No, we haven't really focused much on that initial injury.
Yeah, okay. So, but it's clear that he had probable cognitive impairments or sequelae as a result of that. And I also noticed that the patient had anosmia and dysgeusia. So you say, what is anosmia and dysgeusia? So So I'm going to digress on that for a minute and come back to this slide. Anosmia is the inability to smell, or a disturbance of smell. And actually, that slide should say dysnosmia or not of anosmia. Dysnosmia is a distortion of smell, or a distorted perception of smell. Anosmia is the absence of smell. And it's fascinating because one of the predictors of failure to return to work is the presence of dysnosmia or anosmia. And I'm not talking about people working in the food industry. So you ask the question, well, why in the world would anosmia or dysnosmia be related to someone's capacity to return to work? Well, as it turns out, I'm going to digress into anatomy here for a minute. This is the bottom of your skull, and as you note, there are all kinds of little dips and peaks and valleys, and this surface has ridges that are rather sharp, actually, and there are ridges here that are rather sharp, and you have brain tissue laying on top of this bony, irregular surface. So if your brain is rattling around and shifting back and forth because you just hit a tree, then it's likely to bruise or contuse those surfaces of brain. And that's the areas specifically vulnerable happen to be the inferior surfaces of the frontal lobe and the inferior and mesial surfaces of the temporal lobes. These two regions are the most vulnerable. So at the base of your frontal lobes are two things called olfactory bulbs, which are responsible for your sense of smell. So if someone has a contusion in this region because your brain was bouncing across these rough surfaces and getting bruised, then that's going to potentially alter your sense of smell. Well, so what does smell have to do with return to work? Well, as it turns out, these same orbital frontal brain regions are very much involved in mood regulation and affect control. So it's these very brain regions that tell you to stop when you have the impulse to strangle your boss. And so patients with orbital frontal lesions not only are typically anosmic, but they are impulsive and dysregulate mood. And as a consequence, they often have significant difficulties adjusting at work because of the neurobehavioral difficulties associated with that. Similarly, we have the problem of dysgeusia, which is really fun to say. You may want to practice it a few times. Or ageusia, the absence of taste. So the sense of smell, or taste rather, is in fact mediated by some very similar regions in the brain, including the orbital frontal cortex, and then on the mesial surface of the temporal lobes, called piriform, it's a mesial, it's mesial temporal lobe, which is also very close to some of the primary memory centers, which is another reason most of our patients have memory impairment. But these piriform cortices and the thalamus are all involved in the perception of taste. So often patients will tell you, if you ask them, although they often look rather startled when you do, if things taste different, or if there is a change in their food preferences, or if there are certain foods that they find now very unpleasant. We don't have a way to test taste. We can only do it by questioning. In contrast, for anosmia or dysnosmia, we have an incredibly expensive scratch and sniff test. For those of you who have had children who enjoyed scratch and sniff things, we have one too. It just happens to cost about $40 per booklet, and is also scientifically valid. So assessment of these things can be actually remarkably important. And he apparently had disturbances of smell and taste ever since he got hit by this tree in 1993. So Michael then has a motorcycle accident in 2001, and I gather a deer ran out in front of him, which in Indiana, I'm sorry?
2011.
Oh, 2011, yeah, sorry. This deer runs out in front of him, which in Indiana happens not infrequently. Rebecca, do you know where he was acutely hospitalized? I know that.
Evansville?
Was it Evansville?
Yep.
Okay.
Yeah.
So he required.
Continuing with services down there, got a lot of rehabilitation.
Yeah, great. So he had a craniotomy for a left parietal epidural and a left temporal subdural hematoma. He also had contusions in the left and possibly the right temporal lobes and frontal lobes, consistent with the pictures you just saw. Had a 3-week coma, which is, of course, severe. In fact, if you look at the combination of his subdurals and contusions and a 3-week coma, all of those add up to clearly a very severe brain injury. Initial diagnostics revealed a Broca's expressive aphasia, impairments of orientation, attention, memory, executive functions, problem solving, and intelligibility. Rebecca, do you want to comment on Broca's expressive aphasia, and for vocational rehabilitation folks, just explain what that's about?
When someone has injury, and if they're right-handed and have a left hemisphere focal injury, they often will have expressive receptive language deficits. And actually, he had difficulties with understanding as well. But a Broca's aphasia is someone who has difficulty in expressing their ideas in words and putting words together in sentences. Often they use what we call telegraphic speech, where they may talk simply in 1 or 2 words, often concrete nouns, and they're not able to put their words together in sentences. And so, at least acutely, he demonstrated significant difficulty in expressing himself verbally. He also had difficulty in understanding the speech of others, but his expressive output was more impaired than his ability to understand. That was in the late summer of 2011, and when I evaluated him in May 2012, he was diagnosed with a mild anomic aphasia, which indicates he continued to have some language processing impairments. But he was able to express himself in cohesive sentences. As a matter of fact, it was interesting at that point, more his right hemisphere impairments were demonstrated in his expressive output, and the fact that while he was talking in sentences, his language was very unorganized and tangential, and so that was more, frankly, of a problem than the aphasia.
And that was noted, Rebecca, when you started, when you did your evaluation.
Yeah, that was about 8-9 months post-onset.
Right. So if we look at the next slide now, I've got somewhat of a timeline following the second traumatic brain injury. So I didn't know where his acute hospitalization had occurred, and then he went to Health South Acute Rehabilitation Unit, and then on August 8 was discharged, then home with his brother. I gather then he was referred to the IU Morgan County Hospital for outpatient speech therapy, where he was seen up until when you evaluated him, Rebecca?
That's correct.
And
his intensity was relatively light given the severity of his impairments.
Yeah, I think, and as I recall from Pam, there was a Medicaid issue there as well.
Just recently that has happened. He did receive Medicaid. His family applied for that when he was still hospitalized in Evansville, and the Medicaid did come through. So he did have that Medicaid until, I would just say the last 2 months. Is that correct, Rebecca? Because that affected his transportation.
When he came to us, he did have Medicaid, but they were only authorizing services once a week or once every 2 weeks.
Okay, thank you. And so and Pam may want to add to this, or Rebecca, you may want to add to this. So Sandra Culp then got this patient. Actually, the patient contacted Nancy Griffin, who's the local support network leader in this region, and she then contacted Sandra, and Sandra then in turn made this referral for resource facilitation. And the patient was seen on March 20 of 2012. Interestingly, at that point, and maybe this wasn't new, but the brother apparently very much felt that this gentleman didn't really need any therapies and didn't really need anything, and should just go back to work and should just start driving again, despite the fact he wasn't released to do either. But would not transport him and did not support him applying for a Social Security disability, which certainly left this gentleman isolated and unable to access resources. So anyway, so then through the process, then it was arranged that this gentleman would get to you, Rebecca, and as I gather, you saw him on April 3.
That's correct. He participated in a comprehensive speech, language, and cognitive linguistic evaluation where we looked at all aspects of performance, and at that point, both resource facilitation and Sandy believed he could benefit from more comprehensive and cognitive-based services, and so we objectively tested him then to formulate goals with him.
Great. And how did he receive that evaluation, Rebecca?
Oh, his brother did bring him down for that evaluation. It was a 3-hour assessment where we tested him and then provided some suggestions to them. And that was near the end of the spring semester, and we wanted because the clinic was going to be closing due to the semester break, there was going to be a break before he could start in the summer. His brother was not completely convinced that there would be any difference in the therapies that he would receive, cognitive therapies versus what he was already receiving, and also wasn't convinced that he needed more therapy than he was already getting. And so I had multiple conversations with Michael over the telephone as Michael was trying to make a decision about stopping the therapy he was receiving in Martinsville and starting the services at IU. And the therapist he had was doing a good job and I think really supported Michael in trying to make the best decision. Michael spent a lot of time going through, I sent him a copy of the written assessment with goals, and he called me numerous times wanting to talk about content in the report, wanting to understand things before he made his decision to come to IU. That was also complicated, though, because he didn't have a way of getting here, and so in order for that to happen, he needed to work with Pam in securing some form of transportation to get to and from the clinic.
Very good, great. Well, so let's continue on, and we'll get into the treatment here in a minute, Rebecca. So I just want to briefly review his education and work history. He graduated from high school in 1979. He started at Butler University, but then unfortunately I'm sorry, there's an error there. Then he had his first traumatic brain injury, not his second. And it appeared...
Not that this really matters, but I think it was Purdue because he was studying agriculture.
Yeah. Mm-hmm. Yeah, so yeah, I think he was at Purdue, and I think he was there a year. Is that correct?
Mm-hmm. Yeah, he had a scholarship.
Yeah. So he had some cognitive resources, or we might presume he did, and then had this first traumatic brain injury and never returned to Purdue University. But what he did do then is he began working as a carpenter, and I gather he also worked as a service station attendant prior to that time, and a machine adjuster. I'm not sure what if we have more specificity in that or not. Does anybody know anything about that?
Well, I do believe that he was the machine adjuster first. I got the impression that he really didn't want to go back to school, and he was just trying to find a good job to support his family. He did end up getting divorced, and he decided he wanted to do something that he really enjoyed, and that was the carpenter work. And that's where what he was doing when the accident happened.
Great, thank you, Pam. And he'd been in that. Do we know how long he'd been in that position as a carpenter when the second injury occurred?
No, I do not.
Yeah. Okay. So.
With that individual when he was injured, because that prior relationship served well after his injury.
Oh, is that right?
Yes,
Okay.
I think.
Are you talking about the gentleman that he's now working for? He worked for prior his injury, correct? Is that what you're talking about?
Yeah, I think the issue is he was working for the same firm prior to his injury that he is now. Is that correct, Rebecca?
Yes.
Yeah. So the team in this case is three key players. Pam Nieheiser is our resource facilitator. Sandra down in Bloomington, the specialist in brain injury, and then Rebecca at IU Speech and Hearing, who I will brag for a second, Rebecca. I've had the privilege of working with you for over, 25, 30 years now, and is working with us at a national and an international level in the area of cognitive rehabilitation. So I would certainly classify you as an expert. So Rebecca, you want to talk about your treatment with this gentleman?
Sure. We recommended 3 one-hour sessions a week. In addition, that he participate in our aphasia support group, which is 1 hour a week, and our brain injury support group, which is once monthly. That was quite an increased intensity of what he was receiving before, but given this gentleman's young age and the complexity of his language and cognitive impairments, I felt if he was going to have the opportunity to return to work, we really needed to more intensively address these impairments. And I was privileged that Sandy agreed with that and would support him in those services. So he came down Monday, Wednesday, Friday for 1 hour each of therapy, and then Wednesday he would stay for aphasia support group. He really liked the aphasia support group because in that context is where he met, at this time we have several gentlemen who are near his age that also have aphasia. And he really felt for the first time he was meeting other people that understood what his problems were and had opportunity to learn and practice skills with them. Initially, he, I think, felt less comfortable in the brain injury support group, but that has changed over time, and he has continued to come every month to the brain injury support group. So he, in addition to the individual therapies, he has some of these more group-based treatments. And I do think the interactions with other people that have similar impairments has been really rehabilitative for him as well. In terms of our individual therapies, we've hit several things very hard. We've intensively addressed the residual word-finding difficulties, which is the residual of his aphasia. Very aggressively, we've addressed his attentional impairments. He has an acquired attention impairment that particularly, and given his left temporal hemisphere, left parietal hemisphere issues, in addition to the right hemisphere problems, it's not surprising that he particularly has slow auditory processing difficulties and has a lot of difficulty in auditory attention. And that really impaired many functional kinds of activities. And so we addressed the attention in a very comprehensive way through an evidence-based practice called attention process training that he had 3 times a week. And then we also addressed more pragmatic discourse management, which is now that his language was coming in place, how he did regarding organizing the things that he was saying, listening and turn-taking in conversation, not interrupting, focusing and using information that other people were saying to then make decisions about what he was going to share next. And so those are really the three primary targets of our treatments with him. He engaged in setting his goals, and at the end of every week we would talk about the goals that we had and his progress toward those goals. He had a homework binder that every night he worked on, and we would keep track of the things that he had done, and we would go through that with him and give things back to him or provide suggestions or oftentimes positive feedback about the work he had done. And then it wasn't until this fall we began to have some interaction with his employer. And throughout all of this, we had conversations with Pam and Sandy about the focus of the treatments that we were doing and his readiness for driving and returning to work. And Pam was involved with him as it related to some financial issues.
Great. That's a great summary, Rebecca. Thank you. I'm going to ask Pam now to just comment on her role over the course of this case.
Well, I believe my role was the support with his family. They felt that he could go back to work, he could drive, and as Rebecca said, that they really weren't sure that they thought he could get any better with more therapies. They thought he was doing fine. Michael repeatedly would share with his brother that he wasn't comfortable in driving. He wasn't comfortable with people and talking in conversations and explaining himself, but yet his brother constantly sent him out on his own. And when I first met them, they had all the books, for brain injury. I was very impressed. I thought, wow, these people have all the information here. But unfortunately, those books, either they were read and they were not understood, or they just were on the shelves. His family, he had brothers and sisters also that had some background, I believe, with the state as far as information with Social Security and disability and whatnot. Michael has not received that, but I was able to go with him and help him go through the process with his aphasia. It is hard for him to get the words out, and in the beginning, he's doing much better now, but in the beginning when I started with him, just getting his words out and explaining things, and I was able to assist him and go with him to the Social Security office. Also, another thing, he had put on some weight. He had some balance issues that he was concerned about and really was not doing any physical therapy. So we went on the looking for a gym, but unfortunately he had no income coming in. He was living off money that he had received on an insurance policy for his motorcycle. And I was able to find him a gym, talked with the people there. It was in walking distance, and they gave him a 6-month scholarship there. So he was able to work out anytime, any day, and it was actually a 24-hour physical fitness center. So that was great. I've been able to meet with his employer, also share with him on what Michael's doing. He's very supportive. And then I think I mentioned earlier that Michael has lost Medicaid because of a money situation. And so now we are looking for insurance, and I've been able to help him find some other insurance companies that hopefully continuing to work that he'll be able to afford for right now.
So terrific. Thank you, Pam. So what has come out of this intervention? So I just now want to kind of share with you, and Rebecca, dial in because these are your data. These are his test results on the R bands. Do you want to comment on these, Rebecca, or I can, whatever you like?
Well, the R-bands is a screening tool that it takes 25 minutes to assess, you can see a whole variety of more complex functions, and so I really consider it more a screening tool, but it is a nice way to measure some change over time. And it's a test that can be re-administered, so I had administered it when I first met him in April, and then at the beginning of the fall semester, we re-administered the entire battery. And you can see in several areas he had made some continued improvement. I don't think this demonstrates all of the gains he's made by far. And frankly, it shows here that he came down in attention, but we felt like he didn't fully understand one of the directions on that. So anyway, it's a tool that we can use in addition to other measures as well as some just functional information about what he's doing in day-to-day life.
So I also think, Rebecca, it's interesting. I wanted these data in here because sometimes there's a controversy about whether or not people can make improvements in their cognitive functions, at 6 months after injury or a year after injury or 18 months out of injury. But obviously this patient has made some clear objective improvements in his cognitive functions over a year post-injury. Do you want to comment on that?
Yeah, and actually, when I look at this, the attention really bothers me because that's an area he's made so much improvement. But yeah, Michael is one advantage we have with him is he is very aware of his impairments, and so that's not a barrier that sometimes you can have with people with brain injury. He knew where his problems were. He was acutely aware of them online. He knew when they were occurring, mostly. And so we had that advantage that he was aware and motivated to work through these things. And so we approached him with a variety of both more restorative type treatments, like the attention process training I addressed earlier, as well as some compensation directed treatments where we were helping him learn strategies and putting in place tools and routines to compensate around those areas of cognition that continued to be difficult for him. He's really made significant improvement in his attention. We just today went through with him reviewing some video from the beginning of the semester, and what's really fun for me to watch with him now is the attention process training is a very task-oriented type of treatment that's aimed toward helping recover sort of substrates of attention. But we try to do a lot of activities to generalize some of the changes that he was making into functional skills. And when you look at his discourse, it's clear to me not only is that language-based improvement, but it's improvement in how he's using his language, and I think the attentional skills are supporting that. He's much better able to listen and understand and keep his attention focused, and as he's conversing, keeping in mind where he is going with his stories, and so his functional discourse is much improved.
So, Rebecca,
that's some of the intentional as well as the language-based improvements.
Yeah. So, can you comment about the relevance of those cognitive changes for then your ability to work with Pam to get him back to work?
Well, it's sort of the foundation of most everything. I think when he first went back to work, he was very weary and he was concerned about his ability to do his job well. And so we talked about strategies with him, and I spoke with his employer about what to expect and things that we could put in place to support him. His employer was incredibly supportive, had a family member who also had a disability, and so was very empathic to some of the needs that he would have. And so I think we had nice opportunities to sort of titrate in his return to work so that he could accommodate his strengths and weaknesses, and they could support him well at work. And he's becoming more and more independent. If that answers your question.
Yeah, absolutely. Pam, do you want to add any comments to that discussion?
No, I can't really.
One more comment again. His awareness is an attribute. He just told us that they're starting to build a house next week with the employer he's working on, and so some of the aspects of that job would require him to get on a ladder, and he's not feeling ready for that yet, and so they've made some decisions about what he'll be doing at the work site because of that, and I think some of that was directly related to his planning and thinking about what would be safe and what he'd be capable and able to do, and I think that's good decision making.
Yeah, great, absolutely. Okay, terrific. So the next slide here, what this shows us is are the results from the Mayo Portland Adaptability Inventory. The Mayo Portland, it's the participation index that we use for resource facilitation. The Mayo Portland was developed by a colleague of ours, Dr. Jim Malik, when he was at Mayo Clinic. And it's a measure specifically designed for people who have experienced brain injury. And it has 3 subtests. The first subtest is a measure of abilities that can be affected by brain injury, like memory or speech or ambulation. The second subtest is a measure of adjustment. So it includes the items that relate to their emotional stability and regulation, their relationships with family and friends. And the third subtest is a participation index, which includes things like are they able to drive? Are they able to return to work? Are they able to perform activities in the community, such as doing their own banking or shopping and the like? And so it's a measure that very nicely models this biopsychosocial model. We're looking at abilities that are biologically based. Please mute your phone, thanks. We're looking at the psychological level with the adjustment subtest, and then we're looking at participation, which on that model that we were talking about earlier is at a societal level. And it's a measure of disability. It's not a measure of impairment. So the Mayo Portland is particularly useful for looking at how severity of injury relates to disability, because as we said earlier, you can have a severe injury with relatively little long-term disability, and you can have a mild head injury or a mild injury at the level of impairment, but have relatively severe disability. So there's not a one-to-one correspondence. So we use the Mayo Portland. When this patient started with resource facilitation, he ended up in the moderate severity level of disability, and that was in April of 2012. And what's remarkable is that then since April, which is a mere 7 months ago, this gentleman has made significant progress. Less is better on the Mayo Portland because it's less disability. So we got a rating from the patient, thanks to Rebecca's assistance, a couple days ago, and you can see where he rated himself as moderately disabled back in April, and he rated himself on the mild to almost no disability level. Rebecca and her team rated him on the Mayo Portland the other day and saw him as a tiny bit more disabled than he saw himself, but that's not a clinically significant difference there. So we see a significant reduction in disability at 1.5 years post-injury. So I thought that would be interesting data for you to share as well. So now he has returned to work, and it was it in October, Pam or Rebecca? You know?
He started to spend some time at work, just a couple hours a day in the beginning.
Okay. And same employer, doing construction, no ladders. Do you have any more detail about his work activity?
He shares with me he's still not able to do the more complex carpentry work that he did before, particularly things that have lots of multiple steps that require a lot of things held in working memory. but he, so typically they give him a task that might have 1 or 2 or 3 steps that he'll work on for several hours at a time, but his attention now supports him well in that kind of work.
Great. And so, and the idea is, I understand that he's going to return to work full-time in January?
Well, he tells me the only thing keeping him from full-time return to work is coming to therapy, because the work is there, and so we're making some modifications. The semester's ending here in 2 weeks, and so we're reducing our recommendations for his participation here to 1 session a week with aphasia support group, and so that'll be the only thing that is keeping him from full-time employment. So I think he'll probably equal about 40 hours at that point.
And what is his driving status now?
He's going to be taking Pam worked with Sandra to secure an authorization for a driving evaluation, and that's been scheduled.
Very good. So I just want to share some more data with you. So this gentleman has returned to work part-time. He also completed a satisfaction with life scale when he started resource facilitation, and I just want to review the items on that scale with you. So items on there include things like, in most ways, my life is ideal. The conditions of my life are excellent. I'm satisfied with my life, etc. You can see those. If I could live my life over, I would change almost nothing. And you can score a 1 that you strongly disagree with that, or that you can score a 7 so that you strongly agree with that. And the way that these questions are written, they're all in the positive, I'm not sure what word to use, framework, they're all positively written. So the possible range of scores on this is 7, which would mean that you are incredibly dissatisfied with life. And a score of 35 would mean that you're incredibly satisfied with life. So we administered that in April of 2003, and you can see that his score was just about a 7. And you can see that the other day his score was at about a 24. Which represents a huge change in how this man feels about the quality of his life. So I think that's just hugely telling about where this guy sees himself at this point. So Rebecca, do you want to comment any further about your plans from him? You're going to, he'll stop therapies this semester. Will there be...
Stopping therapies, and frankly, we haven't had our final conference yet. At the end of the semester, we meet with the entire team and review the progress and discuss next steps. So I can share what I'm recommending. It will be up to the team to decide ultimately what happens. But I'm really pleased with the progress he's made. I don't feel like he's done yet, however, and I also think that as he's spending more time at work, potentially he could increase the complexity of tasks he's doing, and there might be a role that we could play in supporting him in that. So we're making a recommendation that he go from 3 individual sessions a week to 1, and that he continue in the aphasia support group, which is Wednesday evening. And so we thought we'd bring him in for 1 therapy session the end of the day on Wednesday, and then he could stay for group, which would keep him to 1 trip to the clinic a week.
Yeah, that's great. And so, Rebecca, would you comment on why you want him to continue in the support groups?
Well, I think the support, frankly, he may continue in the support groups for a long term for a couple of reasons. The support groups give people the opportunity to practice skills in a more real-life, functional way. Also gives the opportunity to talk about challenges they're having out in the community and what they could maybe do to improve their function or to better understand other people's reactions or how they may be able to manage or cope with situations better. And Michael really gets the support group. He likes the support group. He feels he has allegiance with the other members in the support group. He shares his feelings and ideas and perspectives and then uses opinions and suggestions given by other participants. And so I think those are all really positive things. One more thing I'd like to share, which I was just super excited about, we had our monthly support group just met last Monday, so a week ago, and we had a brand new member come in. I had evaluated another gentleman on Sandy's referral also with a brain injury, and I had recommended that he come to support group, and they were going to start that night. And I grabbed Michael and I said, there's a new gentleman coming who lives near you and had an injury in the same way, and he's not sure what he feels about coming to group, and maybe you could introduce yourself and sort of be his mentor in that group that first evening. And boy, did Michael embrace that role, and he waited for the gentleman to arrive and introduced himself and then mentored him through the group and sat next to him, and at the end of the group, the other gentleman was feeling, really accepted in the process, wanted to come back, and I think it made Michael feel real competent in a lot of ways that he could serve in that mentor role with the other gentleman, and so I felt like that was good for both of them, and so frankly, I hope he continues to participate in that process as well.
Yeah, that's terrific. And do you think that his participation in the support groups will also play a role, Rebecca, in helping him sustain his employment?
I hope so. Another thing I haven't brought up, but when people discontinue all their individual therapies, you can come to support group as a way that I can track them informally, and so if little things begin to bubble up, they might mention that to me, and it gives us an opportunity to intervene before maybe problems could get larger. And so he's got a great employer who really seems supportive, and so I don't think any rash decisions would be made if Michael began to have problems, but I think Michael continuing in the support group gives us that opportunity to sort of track and keep our arms around him a little bit, and if there are problems, he can bring that in and talk to other members in the group as well as the facilitators of the group.
Right. Great. Thank you. So this next slide, I think what I want to come back around is before we started the case study, I talked about access to services and how resource facilitation creates those opportunities, and I think this case has illustrated that in a couple of different ways. And we look at access to specialty care like he has received with you, Rebecca. The driving evaluation will be done by people that specialize in doing driving evaluations with brain injury. And so I don't think, based on the research in this area and based on this case, I don't think we would see the kind of change that this man has made without access to that kind of expertise. So we really appreciate your engagement, Rebecca, and working with him.
My pleasure.
The access to social support, I think, has been critical in preventing problems and also helping him with community reintegration. So he got into the Brain Injury Association of Indiana support group there in Bloomington, as well as your aphasia support group, which represent the kind of social supports that we know that make a difference in adaptation and long-term recovery. He had access to instrumental supports, so he got access to Social Security and assistance with that, assistance with the application, and got access to transportation, which is a frequent barrier. In fact, when we were looking at we were doing some statistical analyses on patients that got resource facilitation. I think the sample size now is 61 in this particular cohort. And what we found was that accessibility of transportation was correlated with a 0.001 level with return to work. And that's why it's now on our assessment, because obviously I don't need to say that to you people, but Indiana does not have a comprehensive transportation system, and so it's a critical issue. And then access to community supports. So Pam, finding this gentleman a fitness center that he can access represents now a natural support that he has available to him to help him with his endurance, which may well have played a role in his ability to return to work. So that kind of gives the holistic or comprehensive view, if you will, of what goes into resource facilitation and why it seems to be the case, based on all of our data, that about 64% of our people are returning to work. So this, I need to put this in here because none of this would be here without the HRSA grant and the VR collaboration. And we're very appreciative of working with Voc Rehab on this endeavor and working very hard to get resource facilitation services throughout the state. And now would be a great time if you have any questions.
Well, this is Rebecca, and just essentially a plug, because I've been working with individuals with brain injury for, as you said earlier, almost 30 years. And the resource facilitation model, I think, really has facilitated people with brain injuries' opportunity to get the services that they so need to make a difference in independence and vocational services. You just brought up transportation. I can't tell you how many people I have evaluated from the Martinsville area, which is where the Stillman's from, who we have believed would be could benefit from the kinds of services that simply because they can't get here, they don't get the services they need. And so I've been fortunate to be one of the geographical areas that provides this service, and it's really, I think, made a big difference to the outcomes of the people that we treat because of the role of vocational rehabilitation and the resource facilitator in keeping all of these things moving forward. And so one thing such as transportation or lack of money for medications or something to that extent doesn't serve as the one barrier that keeps somebody from achieving a good outcome.
Thank you, Rebecca. Any questions, folks? I know it's Friday afternoon, but I'm not going to break into Frank Sinatra. So, you know, if you ask, well, I might if you don't ask questions, and you'd be better off to ask questions, really. No. So there don't appear to be any this time. It is Friday afternoon. If you do have questions or comments and you want to email me, please do. Or if you want to email Pam Nyheiser, please do. I didn't put our emails up here, but mine is lance.trexler@rhin.com. And Pam's
is pamela.nyheiser@rhin.com.
How to spell
Nyhiser.
Right. So please let us know if we can help, and thank you as always for your time and attention. All the best. Bye.